Hi, my name is Shaji Kumar. I am a hematologist at Mayo Clinic in Rochester, Minnesota. We're going to be talking today about the concept of early intervention in multiple myeloma, specifically the treatment of patients with high-risk smoldering multiple myeloma. As you're all aware, active myeloma represents one end of the spectrum of monoclonal gammopathies. Monoclonic gammopathy of undetermined significance represents the majority of the patients or individuals with a monoclonal protein in the community. Epidemiological studies over the years have shown that the monoclonal gammopathy probably arises in the second or third decade of life and gradually progresses on to become active myeloma in about 20% of individuals with monoclonal gammopathy. Now, the clinical manifestation of progression from monoclonal gammopathy for undetermined significance are predominantly in the form of active multiple myeloma, but can also be other related plasma cell disorders like light chain amyloidosis. It can be Waldenstrom's macroglobulinemia when it evolves from IgM monoclonal gammopathy of undetermined significance. And then there are a plethora of different relatively rare conditions where the manifestations are related to abnormal deposition of the protein or more along the lines of a paraneoplastic phenomenon that can happen in the context of a monoclonic gammopathy, where the mechanisms are not all fully understood. The risk of patients getting any of these, particularly the active multiple myeloma, um, is about 1% per year among people with monoclonic gammopathy of undetermined significance. What we do see is that in some patients, the clone gradually continues to um, grow, and eventually patients develop symptoms of active myeloma. We already know that once patients develop active myeloma, even though the current treatments are highly effective in controlling the disease still remains incurable at that point in time. While the treatments are effective, this also involves giving prolonged therapy, often for the entire duration from diagnosis in a significant proportion of patients with myeloma. In addition, when patients actually develop active myeloma, its manifestation can be catastrophic, particularly if it affects bones with bone fractures that can at times also lead to spinal cord compression and significant neurological adverse events. In addition, there can be significant renal damage secondary to the disease progression that can lead to renal failure, some of which may be irreversible, and can not only compromise the therapy that we can give for the disease, but also the increased mortality that comes with it long term. So the big question that we have in front of us is, does it make sense for us to do something early on before the active myeloma actually happens? So in an individual where we already know they have a monoclonal gammopathy, at what point do we jump in and do something about it? In the past, we have not done any early intervention along this spectrum prior to patients presenting with CRAP features because, for one, we did not really understand the natural history of the disease, of the natural history of monoclonal gammopathy. We did not know who is likely to develop active myeloma. We did not have drugs that are very safe for us to be giving it to an asymptomatic individual. And finally, there was no prospective data to demonstrate that it actually led to any improved outcomes for these individuals with early interception. Now, that whole paradigm has changed over the past decade and a half, with several large-scale epidemiological studies clearly outlining the natural history of smoldering multiple myeloma. Now, we clearly understand that nearly 40% of patients with smoldering multiple myeloma will progress to active myeloma during the first 5 years after diagnosis, with an additional 12 to 15% of patients progressing in the subsequent 5 years. And beyond that, the risk of progression seems to be similar to that of monoclonal gammopathy of undetermined significance at about 1% per year. Now, the 50% of the patients who are likely to develop myeloma in the first 5 years, the question is, can we do something about those patients? Can we delay the onset of myeloma? Indirectly, meaning we are delaying the initiation of this continuous myeloma therapy. But at the same time, we also preventing some of the catastrophic manifestations of the disease with which these patients can actually present to you when the disease actually does progress. So, so we certainly know the natural history better. There have been better risk stratification system like the International Myeloma Working Group and the Mayo 20 to 20 risk stratification and the scoring system that was subsequently developed by the International Myeloma Working Group. In addition, there have been other risk stratification systems that looked at dynamic changes within the disease parameters and other laboratory values that can alert us to the likelihood of progression or increased risk of progression. So I think we have gotten a lot better at identifying patients who are at the highest risk of progression. Can we identify every single one of them? Probably not with this system that we have. And can we correctly identify 100% of them? That is the specificity of these risk stratification systems. Again, not quite 100%, but upwards of 70% to 80%. So certainly some work more needs to be done, particularly with respect to looking at genomic markers and so forth, and that work is in progress.